Um, Welcome and thanks for making the time this morning. I think you'll find it to be a very informative meeting today. We have some great speakers and guests that are going to be able to go through a lot of information for us. The focus is on the depression screening. We're quite grateful that MedInt has agreed to join us on this meeting today and shed some light on how we might manage collecting and coding and documenting the depression screenings and being able to capture it, as well as Hixney is here as usual. Ruth Ann Craven is a permanent part of our group, and we're quite grateful for her expertise as well. I do want to do one call out. Claudia Higgins, who is our administrative support person for this meeting, this group, this work group, the prep meetings, someone who has kept me on task week after week and reminding me, to keep up on things, and things are due, and make sure we get these things out, and what about this and what about that. She's been a phenomenal assistance with keeping this group straight and tracking records and things like that. She has chosen to retire at the end of this month. So she will be leaving us at AHI and leaving this team as well. But we wish her well and congratulations on her retirement.
Thank you very much, Luann. It's really been a pleasure. Really been a pleasure.
We will miss you. This
Yeah.
is the first I've heard of it, but I wish you all the best luck in retirement.
Thank you so much, Kate.
So without further ado, if there is no other announcements, Brenda, do you have anything specific announcement wise? Okay, let's go ahead and get started. As always, I'm going to remind everyone about PCMH. I don't know where you're at with your trackers. You can go to the next slide, Claudia, thank you. But I would call out, have you looked at your quality improvement plans? And some of what we've been talking about here is the ECQM opportunity we may have. But again, with the PCMH, you all have submitted your quality improvement plans in the past. And again, looking at what you've got on the docket for 2021, it's a good time to pull that tracker out and see where your quality improvement plans might be at. And if there's any way we can help, or if you have any questions about any of the metrics, by all means, raise those questions here. You can always reach out to myself or Brenda. And we do have a lot of subject matter experts on this team should you need specific examples or someone that has seen a great success with one of their quality improvement initiatives. So don't hesitate to ask, and we can always find someone that might be able to help you.
Luann, this is Julia Gerard from Glenfell Hospital. Is this a time when I could ask a question of the group, or did you want to wait till?
Nope, go for it.
So we're in a situation, just looking for the group's thoughts, and this is kind of on behalf of Anne Marie Hatch and myself. Our current recognition period is from December 5th of 2020 to May 28th of 2021. Short time period because of the extension with COVID last year. And we're just looking to see, what thoughts are. Is, can we use the month of December 2020, just that month, as our baseline or remeasurement period?
So that's a great question. And I think with everybody in their short time frames, they're, trying to figure this out. But my understanding is, as long as you haven't used that data or that month's data in the past, you can use it as long as, it's kind of like clean data that they haven't seen that already. So that's been their biggest feedback that we've gotten from some of the reviewers, that you can go back up to a year from the time you're submitting, as long as you're not using previous data you submitted. Is that helpful?
Okay. Yes. Normally, what we're submitting is usually a quarter worth of data. But in this case, because of our filing and all of that, we're not prepared to use the first quarter of 2021 data as yet. So really all we have is that month of December.
Yeah. And again, the reviewers have been very generous and understanding of our extenuating circumstances. So when it does come down to submitting data, they've been very generous with people not necessarily meeting numbers or having to use a shortened time period because of the challenges with COVID and just getting people in. So I do believe that, they'll take all of that into consideration. The other thing I always recommend is to reach out to your reviewer specifically and share that information with them up front that says, this is what I have, this is what I'm going to be submitting, and at least they can comment on it if they have any thoughts or ideas that might be able to help you.
Okay, I appreciate that. Thank you very much.
Absolutely. Anyone else with any thoughts or comments on that topic? Okay. Next slide, please. Katie Cook. Katie Cook is with us, and I think will be, again, joining us as much as she can with her time schedule. Katie Cook is our resident telehealth expert, and I think she has some updates that would be helpful for all. Good morning, Katie.
Good morning. So I have a few updates, more of an ask of the group today. Last week, I had sent Luann an email, actually 2 weeks ago, around telehealth data. So as many of you probably get my emails every quarter, the program that I help to oversee the North Country Telehealth Partnership is a Department of Health Rural Health Network grant. So we have a work plan and we have certain metrics that we try to hit. And the data that we ask for through the spreadsheet that I've created over the years allows us to paint a picture that shows telehealth growth in the region, shows DOH that we are working hard on expanding telehealth and being a resource for the region, and allows for continued funding of the work that we do. So in an effort to better understand the process, I've been having some calls with our Fort Drum counterparts around the best way to ask for data so that it's not a burden to any of you. So the question that I am asking of the group today is around the process to pull a report that shows telehealth encounters for your practice. How do you go about that? Is it an easy process? And how are you differentiating between what is a telemedicine visit or what is a telephonic visit? Do your EMRs have a built-in functionality to easily pull reports? And if you have recommendations for the partnership on making this process easier for you. I think our ultimate goal eventually that Luann and I briefly discussed was that eventually the Healthy Connections, HCSCNE, and other RIOs will have a way to flag telemedicine visits within that system so that we can go in as kind of a super user and pull the data that we need. But I think we're a ways away from that happening. So I want to open it up to the group. Some of you have been consistently sending us data quarterly. Is this an easy process? Are we asking for too much? Should we be asking for more? I'd love your thoughts.
Katie, it's Amanda Wisher from Elizabethtown. So we report quarterly to you.
Yes.
And your spreadsheet is very easy. We use GE Centricity, which is now an Athena product, but we have the capability of creating encounter types. So those reports are easy for us to generate on a monthly or quarterly basis based on the visit type to determine whether it was a telemedicine or telephonic visit. If there's any more detail that you'd like, I can happily get you anything you need, but it's an easy process for us.
That's good to hear. Thank you, Amanda.
This is Angie from Alice Hyde. I report to you quarterly as well. Ours is a little bit more manual process, but for network purposes, we have been tracking our number of visits anyway throughout COVID, and with the breakout of the telemedicine versus the telephonic as well. So I do pull it from a spreadsheet that our administrative assistant collects each month, but it's not that difficult.
Okay, thank you. Appreciate it.
Angie, I have a question. How does your administrative person collect it?
From each office, from each of our offices, they send her the daily stats every day anyway. So she just pulls that off of their daily stat sheet.
And is that like a spreadsheet they submit, or is it pretty manual?
It's a spreadsheet. Well, the form is in a spreadsheet. Some of them fax it to her, some of them complete the spreadsheet and send it to her. So
Got it. Okay, thank you.
Did anybody else have comments on that ease of this? Does their EMR make it easy?
Rebecca with Northwinds. I'm just wondering if you do currently get any reporting from our regional behavioral health providers, and not, certainly not to call out, but just a general idea if they are reporting on this sort of measure. I would certainly be interested to see, especially given the past year. I imagine they're collecting some sort of data around tele encounters because many of them had to pivot immediately all to telepractice. So just curious if that's being collected, if it's something that might be of interest, or maybe we can gather additional partner support to get those to you.
So I do get data from Clinton County Mental Health, Essex County Mental Health, St. Joe's, New Choices Recovery down in Schenectady, Citizen Advocates, looking through some Baywood, St. Lawrence County Community Services. Yeah, those are the ones that are pretty consistent. BHSN are pretty consistent with sending me data that shows the behavioral health and telepractice side of things. So I think I'm probably capturing 60 to 70% of what's really happening, because again, this is a self-reported process. It's not a perfect system, but short of us having access to every practices and partners EHR system, I think this is the best way to go about it right now, but we are getting behavioral health data.
Great, thank you.
Yeah. Anyone else have thoughts or comments on our reporting system? All right. So I had one other item that I wanted to put in front of the group. Some of you have seen this information before, so I apologize if it's repetitive, but I was asked to present this particular flyer one more time as we're kind of stuck on the wording. So I'm running a few telehealth work groups right now. One of them is focused on patient awareness and education. And I've worked with a few others and presented this flyer to a few other groups, a patient-facing telehealth flyer. So I'm going to share my screen. Oh, I can't share my screen, darn it. Oh, thank you. Okay. So here is the,
send it to me or Claudia, we can share.
Can you guys see it?
Oh, yeah.
Okay.
Great. Perfect.
So this is meant to be patient facing with the goal of it, being printed and distributed at different community events that maybe our East team is putting on, possibly even county run or provider-led vaccine clinics, food pantries, things of that nature. So what we're kind of stuck on is my director, Nancy Gildersleeve, brought up a good point that on this flyer, I referenced the term doctor or provider, but that could be limiting because not only doctors offer telehealth, it's healthcare professionals as a whole, but what's a health literate way to say that? So I'm presenting this to all of you for maybe some feedback on this flyer. Is there a better term than doctor? What do you think your patients would understand best?
Hey, Katie, it's Amanda Wisher. What about something like healthcare professional? That way it's a broad.
Yes. So actually Megan Murphy sent me an email the other day saying that exact term. So I think that may be what I'm leaning towards. I was also thinking about medical professional, but I like healthcare professional a little better. Thank you for that recommendation. Anyone else have thoughts on this flyer or the right term to use? Okay. And Luann, I'll send you this flyer after the call so that you can distribute it to the group. I think this is the fourth or fifth time this has been shared. So I think I have enough feedback that we're at a point where we can kind of publish this document and start disseminating it. So I've created a few provider focused resources as well. So I'll be sure to kind of send out a mass distribution to our partners so that they have access to that, and they'll go up on the telehealth website at ahihealth.org.
Great.
Those were the main updates that I had. I'd say I put in a little plug right now. The FCC is going to soon be announcing their round 2 telehealth funding. The FCC did do a press release about a week and a half ago saying that in the next 30 days, the application window will be open. I know some of our partners did receive funding in the first round. This second round, there is just under $250 million available. To be able to apply, there is a little caveat in that the FCC is going to have USAC, the Universal Service Administrative Company, administer the funds. So the funding window is going to open in the next 30 days. Not really sure how long it's going to be open for, but for this round 2, they are asking that applicants obtain an eligibility determination for whoever the lead healthcare provider listed on the application is via an FCC Form 460. So if your organization doesn't have that determination and you're interested in applying for funds, I would recommend looking into this sooner rather than later. You do need a healthcare provider number assigned to you by USAC. I would imagine that most practices have an HCP number at this point. And a few examples of eligible services and devices that you can get funding for include voice and internet connectivity services for up to 12 months, remote patient monitoring platforms and software, platforms and services to provide telemedicine, again, for up to 12 months of funding, and then tablets, smartphones, or connected devices to provide telehealth services for patient or provider use, and telemedicine kiosks and carts. So if that is something you're interested in and you want to talk offline, certainly reach out to me. I will be sending out an email when I see that funding window has opened so that anybody who's interested can take the opportunity to apply. And that was all I had.
Any questions or comments? I will include on this slide Katie's email address as well as the link to the website.
Yeah, I can put those in the chat too.
Okay, thank you, Katie. It is on the AHI website, but certainly a direct link to that page is always helpful. So I'll include that on this slide when we send out the final slides.
Yes, and we recently just did an annual update of the interactive telehealth provider map. Daniel did a great job putting in some new locations. So certainly go ahead and check that provider map out. Make sure that your practice is listed if you're offering telehealth. If you're not listed, reach out to me. If the information is incorrect in any way, please reach out to me. We want to make sure that map is as accurate as possible for both community members to look at, as well as other providers for referral purposes or to see what's being offered in the region.
Thank you, Katie.
Thank you.
So as I said early on, we are very fortunate that we have 2 representatives, Judy Dorsey and Jenna Sorrento from MedEnt here to talk about the ECQM measures. And without any further ado, I'm going to ask Judy and Jenna to introduce themselves and share the information they've brought for us today.
I'm Judy Dorsey. I work very specifically with the quality measures for MedEnt, the development and getting them programmed and so on, troubleshooting as well. And I guess I'll leave it to Jenna to introduce herself.
Hi, this is Jenna Sorrento. I do this similar situation with Judy. We work closely together on all sorts of quality reporting and extracting data from patient charts and reporting in different mechanisms. And yeah.
Great, thank you. I don't know who's going to start, but certainly, Brenda, you want to take this portion?
So Judy and Jenna, I think part of I think our practices that are on the line certainly that utilize MedEnt, and there's quite a few actually that are on. When we're looking at going to ECQM measurement, and especially for our Medicare shared savings, it really changes the landscape of what we're doing with Medicare, because now it's our whole patient panel, where in the past we were doing the data abstraction. So we've seen many things when we're doing data abstraction, finding different data points in different areas. So, collecting that data and getting accurate results out of our EMR, is certainly has been a struggle. I think there's been a lot more work, and I think we'll hear in a little bit from Amy McDonald, some of the new workflow that she's put into place for depression screening. So, if the two of you could speak to some of the things that you have seen, where some of the barriers may be, and kind of, give them some feedback that, over your years of experience with MedEnt, kind of where some of those issues may lie, as well as I know there are a couple people on the phone as well that do have some specific questions regarding 2021.
Judy, do you want to start with that?
Yeah, for the depression screening?
Sure.
Okay. We do see a few issues regularly on the depression screening measure. One is that we need to have the depression screenings filled out in an actual document and not a scanned document. Because we can't read the score otherwise. Another is the follow-up, which is the big issue with this measure. We do need to make sure any patient with a positive test or screening result does have their follow-up documented, and we have all the documentation areas available in our manual. Our EMR support department is willing to help if there's any questions about them. Let's see. That's really all I had for the depression measure. Did you want me to talk about the other two, or Jenna?
Yeah, that would be great, because I think it starts people thinking, Judy, about what, kind of what's happening within their own workflows in the office, and things that you identify, are really helpful, and kind of keys them into areas where they need to go back to their system and start looking.
Mm-hmm. Okay.
Hold up.
Sorry.
I just have a question before we move on. I apologize. Sure. This is Angie at Aliside, and we've been using MedEnt for quite a few years, but can you give us a link or some tips and tricks where to find those details about those measures in the manual? I've been using it for a long time, and I have a really hard time finding the current year information on what satisfies those measures.
Sure, I'll put it right in the chat.
Great, thank you.
Yeah, there's the link for our manual page for that measure.
And that's for that specific measure, but if you wanted to bookmark that on your computer, if you use the same one, you can also do that. I save a lot of them, because just like you, sometimes it's hard to remember exactly where you went, and searching is sometimes a little difficult too. So I tend to bookmark a lot of the tabs that I use so that I can easily reference back to them, because I do, just like you, I use the manual all the time.
Okay, thank you.
Okay.
So Judy, I have a question.
Sure.
When you mentioned that providers have to fill out the depression screening in a document, is there a specific document or a specific data field they need to put that in order for it to pull into CCDs that they send out?
These documents that we have are, well, there's many of them and they're in the manual. They're all listed. They are mainly checkboxes, and the checkboxes will calculate a score determining positive or negative. They're all interactive reports, point and click.
Those are not communicated in a CCD.
Okay, thank you.
Okay, did you want me to move on to the diabetes?
That'd be great. Thank
Sure.
you.
Okay. Yeah. This one, well, it's an inverse measure first. It's so honestly, you want a low numerator to 0 if at all possible. This is one of the exceptions of the rule, so to speak. And this particular measure will put patients in the numerator if they either have no A1C during the measurement period, an A1C without a result during the measurement period, or if their A1C result is greater than 9. And again, it's all contained in the measurement period. So if your patient is seen early in 2021, we are still looking only in 2021 for the lab. So if they don't have it at this visit, if they're back 6 months later, odds are they're probably going to have it by then in the system. So only patients in the denominator are only people with less than 9 A1C result. So that's, people get confused. Well, the fact that it's inverse, or the 3 different area or ways you can end up in the numerator, which you don't want them to be. Jenna, did you have anything to add on that one?
Did you mention the component of checking the box of depression, positive or negative?
Oh, back at that measure? No, I didn't.
Oh,
The score usually calculates the positive or negative though.
Okay. Sorry. I also wanted to mention one other thing about the depression screening. When you mentioned about included in the CCD, I don't know who made that comment, but that's one thing that how is the data getting over to Adirondack ACO at the moment? Because if you're doing CCDs and you're trying to calculate these measures, that's something that we would want to take on another call and talk about a little bit more. Is that how the data is being captured right now?
No, we're actually having the providers send us their reports so we can calculate. Ruth Ann Craven is from Hicksney. And so really, I think ultimately, I think that's work that we would like to see, because if people are sending data, their CCDs, and they're sending their clinic visits to Hicksney, that would be great if we're able to capture that information. So, I think that that's certainly a future state.
Okay, no, that's good with the reports. That's perfect. There is some ways that you can get a depression screening into a CCD in a CCD setup area. That might be another discussion for someone who wants to help setting that up. But even with that being done, it wouldn't be necessarily enough to consider a positive and negative score. This is straying a little bit from what our current topic is, but something that was brought up and it caught my attention. So I just wanted to make that clear that it's most likely not included in the CCD at its current state. There is a way to get it depression screening in, but it wouldn't be at the level of including the actual score. So sorry to sidetrack a little bit from the depression screening measure specifically, but I just wanted to point that out.
No, I think that's helpful for us to understand, Jenna, because certainly, ultimately we'd like to be able to have that information there and available. So certainly we can put that, on a future agenda.
I did actually, I thought of something else for the diabetes measure, and that is that the documentation area, you need to be filling in a lab order. The lab order, the lab test itself needs to have a LOINC code associated with it. We do find occasionally that sometimes they come back from the interface labs without a LOINC, and our lab department can take care of that. They can run a utility to fix that. So if ever that happens, if it ever seems like your numbers are way off, contact MedEnt support to have us check into that. And you also need to make sure that there is an acquired date in the lab order. That was all I had for that measure. Is there any questions for the diabetes measure before I move on?
Hi, this is Angie again. I do have questions and I apologize. You guys
That's okay.
are just gonna want me to call you individually, but so my first question is, as you said previously, because it is the measurement year, when we run those ECQM reports to kind of see what our status is, they don't look so good, even though, like you said, maybe I had a patient who had their A1C in December and they're not actually due, for 6 months. They're gonna be a fallout on that measure, even though we technically wouldn't have ordered the lab for them yet.
Right.
So how do we monitor how we're doing, or do we just know that going forward through this year that hopefully that we'll just see those scores improve over the year?
Yeah, we recommend, running the reports periodically through the year, and I would expect that the numbers will improve over time. And again, it's because of the time constraint of the lab within the measurement period.
Yeah. Okay.
And also all these measures, not just this one, but all these measures are really based on a 12-month time period. So running them just for the first quarter, things are going to look a little weird,
Right. Either way.
Right.
Yeah. I tried them both ways, and yeah.
Yeah, we always recommend filling in the full 12 months when you run it, even though we're only in April right now. Whenever I run a report, I run it till the end of the year.
Okay.
And that way we make sure that the programming and the specifications are lining up correctly as they are designed.
Okay, that sounds good. Then the second thing I had, I'm sure other Medent users are aware of this, but I just want to throw it out there just in case. So we're a hospital that owns practices, and we own the majority of our practices in our community. So most of our labs come through our hospital lab and are interfaced to us. However, we do have a few providers that have a pretty high VA population who get their labs drawn at the VA clinic, and we are not interfaced with them. So I have been working with our staff to make sure that they are manually entering those labs when they come back in, just to make sure it counts, because it does not count when it's a scanned document coming back.
Correct. It has to be a lab because the measure specs actually require a result to be present.
Right.
So that's why it has to be there. But yeah, they would just create the lab order, fill in, choose the lab, enter the result, at least put an acquired date, if nothing else. And that's the bare minimum for the measure to read it.
Yeah. It's a lot of work around.
Yeah.
We have busy practices, but it is what it is. So, and then quick question, Jenna, I pulled up those quality measures. I do not know how, in the manual, I do not know how to mark that as a favorite.
Okay, give me one. So it would be in your actual web browser.
Yeah.
So if you should have maybe a star. It kind of depends on what your browser you're using.
Oh,
Maybe,
okay.
And then that would add it to your favorites or bookmark it. And what I do is I actually add the toolbar. Let me see how I can.
So a favorite in your web browser, not on the Medent
Yes,
manual itself.
that's correct.
Okay.
Yep.
Okay, understand now. Thank you.
Yep.
Okay.
I'm sorry to interrupt.
Sorry.
It's
Go ahead,
Linda.
Brenda.
One of the things that I've noticed, and I don't know, we have a lot of practices now that are doing point of care testing. And is there a specific place that needs to go? Because I have to say, you have to search and search sometimes. And I'm just curious, does that go through a lab as well? Does a lab have to be filled out and that result is put there as a point of care?
Yeah. For this measure, we always need a lab order and a result, regardless of where it's taken, whether it's interfaced or not.
Okay. Thank you.
Okay, the controlling hypertension measure. This one gets a little sticky with the diagnosis date requirement. The way they designed it, the hypertension diagnosis needs to exist either prior to the measurement year, and in Medent that would have to be in the problem list in an active status. If it can also be entered the first 6 months of the measurement year. Again, in the problem list, or that can also be in our DX history with an ICD-10 code. ICD-10 codes we limit to the measurement year because they do not have the ability to document whether it's ever been resolved or not. So it's basically a moment in time when you enter an ICD-10 code. So that's the way our programming reads. So if the hypertension diagnosis has not been in there at least before June 30th of the current year, then the patient will not be included in the measure. They have to have had that hypertension diagnosis either prior to the year or during the first 6 months. And then another thing about this measure is it does not allow patient-reported blood pressures. And with all the telehealth that we've had over the last year, any patient-reported BP is not going to count. Where it specifically states that in the measure specifications, patient reporting does not count, with the exception of a blood pressure monitoring system that automatically reports to a doctor's office. That's the only exception to that rule. So this measure requires a valid encounter. They have to have had hypertension prior. They have to have a BP taken at the visit by a clinician. So all of those in place, and then if their result is below 140/90, they will meet the numerator correctly. Anything above 140/90, they're going to fall back into the denominator. And that's all I had on that one. Jenna, did you have anything else for that measure?
No, I think you hit all the good points there.
It's an annoying measure in general. It's difficult.
So Judy, I had a real quick question because
Sure.
I mean, for the state of, our commercial payers, and I know we're talking, for MIPS right now, but even for CMS for 2020, when we were doing data abstraction for the MSSP, and all during the period where they're answering questions, we were able to include anybody. But for the purposes, I guess you're saying when you were reporting people are reporting directly out of their EMRs to CMS, that they did not allow, because I thought for the public health emergency because of COVID, that was something that if they were able to visually see the person's equipment, that it could be documented.
No, that this was actually one measure. There's not many measures actually specifically state no patient reported. This one does, and they didn't negate it. They did technically telehealth visits for the encounter are allowed for this. That's why it doesn't really make any sense what they did with the combination of the telehealth allowance and the specs. But, because we are not allowed to accept that patient reported, we have to stick to that. We're given these specifications. But yeah, so it honestly, that measure, if they're not going to allow patient reported, they shouldn't allow telehealth. But because of the, like you said, with the, the COVID crisis, they did allow the visits to be telehealth. That's all. So
yeah, that's not, and in fact, I'll have to send you the slide deck where CMS actually spoke to that. And I mean, several of us, because that was for 2020, going forward at this point, I think at any time when they depending upon how we go forward with telehealth and once they lift it, what is that going to mean to everybody again? Because we certainly had some takeaways that kind of gave us a little bit of leniency, especially in our commercial world. There was a little bit more leniency there than what there's ever been. So
yeah, there was a document that it actually specifically stated that providers need to be aware that not every item in the measure, or however they worded it, may not be possible in a telehealth visit.
Right.
And so there was a statement about that, and I can send that to you as well.
Okay, thanks.
Yeah.
So the variance with HEDIS reporting is it can be patient reported if it's a digital device. The patient can't just do it themselves, but the digital device is available to show the doctor.
Yeah, correct.
Okay. Jenna, did you have anything else?
Thank you very much, Judy and Jenna. That's been really helpful. Anybody else have any other questions for Judy or Jenna at this point? We can proceed, and then, you know, if they remain on the phone, if at the end somebody has questions, we can certainly entertain that.
Oh, Brenda, I just found that statement in the telehealth guide.
Okay.
Says there are 39 telehealth eligible ECQMs for the 2021 performance period. This is for the 2021 specifically. When reviewing this list of ECQMs, please note there may be instances where the quality action cannot be completed during the telehealth encounter by eligible professionals and eligible clinicians. Okay. So that is why we're not able to.
Right.
Yeah.
Yeah,
They
for
did
current.
state that. It was the same statement in the 2020 guide as well. They didn't change it.
Okay. Well, they probably gave us a freebie then for CMS when we were doing.
Oh, yeah, yeah. And I would love it to be otherwise, but.
No, I know. It makes no sense. Again, this is where, you know, we start talking about confusion. We're saying one thing for this payer, you know, this organization, and then we've got something else going on for a different, you know, for the commercial side. So, and then the ECQMs. So.
Yeah.
Thank you, Judy.
You're welcome.
Is there anyone else with any questions about ECQMs in general that we might be able to answer or help with, or anybody else that's using MedEd that might have a specific question while we have this valuable resource here with us? Okay, well, we can always take questions at a later date or whenever and make sure we can connect you with those resources you might need to help clarify. Ruth Ann did, as we were continuing to talk about depression screening, we did ask her to perhaps take a look in HCSCN and see what information around depression screening, what data she could retrieve. And so I'm gonna let Ruth Ann present this information. I thought it was extremely helpful and quite positive, actually. So Ruth Ann.
Thank you. So if we go to the next slide, please. Okay, so I did I did a review of 5 CCDs that were received between like the end of March, early April, for each of the practices listed. And I looked at how many times depression screening was documented in the CCD we received, as well as the % of times other screenings, social screenings were documented. And by other social screenings, I mean tobacco, alcohol use and drug use, as well as PRAPAIR, if there was any PRAPAIR social determinants of health documented. In cases where there was a screening documented, I looked to see more about how it was documented and whether it was coded in a way that HCSCN could consume it and share it with the Health Information Network. I also put on here the EHR vendor because I did notice a couple of trends with eClinicalWorks, for example. A lot of information is in the CCDs we're receiving, but it's not coded in XML. And let's see, and then going down like Adirondack Medical Practice for depression screening, I noted that they're doing it as a diagnosis. So Z1331 is the encounter diagnosis they're using for screening for depression. A handful of the practices are pediatric, and I do know that depression screening is only recommended for ages 12 and up at this point. So I did note if out of the 5 patients, for example, for Adirondack Pediatrics, 4 of them were under age 12. So I wouldn't expect them to have a depression screening. So in that case, you know, 1 out of the 5 had a depression screening as well as other social screenings. So I thought that looked very good. I asked the question about where things are coded in MedEnt because a lot of our MedEnt practices are sending us depression screening information. So I think it was just kind of random chance that we did receive some of it, but we are getting some. So I don't know if you wanted me to go into detail on this or maybe just like open it up if anybody has questions about what's shown for your practice.
Ruth Ann, this is Angie.
Yep.
I see we're at 0 And I missed what you said at the beginning, how many you looked at or what the time frame was. Maybe you didn't, but like we're definitely doing this, but I'm wondering if our rural health clinic billing is interfering with that reporting.
Yep, so we looked at 5 CCDs and it was mid-March to early April was the time frame. 3 of your 5 had documented diagnoses of major depressive disorder, so I think they would be excluded from the measure based on that diagnosis. And then since you're using MedEnt, I don't know if it would be pulled into the CCD based on how you're documenting it.
Okay.
Ruth Ann, this is Julia from Glens Falls Hospital. Again, we have the same issue, I think. We're definitely doing depression screening, but we're coming up 0. So we'd be interested in talking to you about the information that was pulled.
Yep, I can send you the 5 patients I looked at.
Appreciate it, thanks.
And I think in that case, you'd need to follow up with Cerner because I think it's not getting documented in a place that pulls into your CCD.
Okay, thank you.
Just
Send it to Anne Marie. Thank you.
This is Jenna from MedEnt. I just have a quick question here. For when you're looking at depression screening was documented in this case, in this particular spreadsheet, are you simply just looking to see if there was a depression screening in the chart? Or are you looking to calculate the measure? Because what I was trying to get at earlier is that the depression screening, whether it was completed or not, just as a general statement of any depression screening, is something that could potentially go in the CCD if it was set up to do so. But the score itself for what the depression screening was and which format of, like, you know, a PHQ-9 or a PHQ-2 in the score, that is something that would not necessarily be able to go in the CCD.
Right. So what I was looking for was any evidence in the CCD that a depression screening was done. So a lot of times it was a diagnosis or it was a HCFX code or it was a procedure. There were a few that actually had the PHQ-9 and the PHQ-2, but that was eClinicalWorks and GE Centricity.
Yep.
But I was looking for any evidence.
Sure. So if any MedEnt practice feels strongly that they're doing a depression screening and it's not capturing, or maybe doing a PHQ-2 or 9 document, depending on your documentation, it's likely that that could potentially be included, and we can review that together if that's something that you're interested in getting set up, so that it can communicate that there was a depression screening occurrence.
And truthfully, that's exactly what this was just meant to do, just to give people, you know, just a sense of, you know, go back and take a look at your documentation within your EHR, and then also how are you connecting that information to your CCD, working with your vendors to assure that it is coming into HCSD. It is a small sample, as Ruth Ann talked about, but it was just kind of a glimpse of information and enough to just kind of raise everyone's awareness that maybe we're, and I don't say maybe, I know many of you are doing that because Brenda gets the information and has certainly seen, you know, positive results that you have shared. But perhaps it's just not connecting to take it that one step further and get it into HCSD, which certainly is a goal of that way, everybody having the information and people being able to review that information from various practices or healthcare providers.
I can actually put the navigation on how to get to that setup area right in the chat in just a moment. I'll do that for you guys.
Thanks, Janet.
This is Angie again. Ruth Ann, do I understand though that you were looking at diagnosis codes and or procedure codes as well on those people?
Yep.
So
I looked at encounter diagnosis, I looked at problem lists, I looked at the procedures section, and I looked at the social history section.
Okay.
I was looking for anything.
Okay, yeah. So I am interested in getting that added to our CCD, but I know that we are doing those diagnosis codes because I have it linked right to the depression document. So
Okay.
that's not diagnosis code, that's a CPT code. I apologize, but I definitely know it's there. So
Okay, I'll send you the examples too via secure email of the 5 that I looked at, so you
okay,
can see if we're not getting it for some reason.
okay.
And I have to say, I mean, when I'm doing chart reviews, the screenings are being done. I think this is just a matter of, you know, understanding what's getting sent. If you're not in there looking at Hixney and what's being sent, you don't know. You know you're doing it. It's just, you know, you're not able to see that on the other end. So. All right.
Okay, thank you so much. And thank you, Ruth Ann, yet again. Great discussions and very helpful information. So next up, where's my screen here? We did, you know, again, trying to further spend some time talking about what practices are doing, is ask a couple practices to share some of the work they're doing. So both Amanda Wisher from Elizabethtown and Amy McDonald from Adirondack Medical Practice agreed to speak. I don't know which one would like to go first. Amanda, I guess you're on the top of the slide, so we'll pick you first. But if you would like to share, that would be wonderful.
No problem. So I just wanted to give a little bit of history before I dive into exactly what we're doing. In 2014, our practices were non-compliant with depression screening. So really taking a deep dive in 2016, we began to educate our providers and educate our staff on the importance of these screenings, especially for the realm of the ACO and medical home. In 2018, we decided that we needed to take it one step further. Education wasn't enough. And we developed an EHR customization form. So our depression screens are completed right in our EHR in structured data fields. There's an algorithm behind the building of the form so that the form only appears every 180 days. So it's capturing depression screens every 6 months. What we discovered was every 6 months wasn't good enough. For example, if a patient came in October and had a depression screen and then came in January, didn't have a depression screen because it hadn't been 180 days, but then never came in for the remainder of the measurement year, we were missing that target audience. So we took the algorithm off, and now the depression screen is available for every single encounter. Staff are trained to only fill it out once a year or every 6 months, depending on the score. And they also are trained whether it's a PHQ-2 or a PHQ-9. The form is built so that if a PHQ-2 scores above a 3, it automatically reflexes to a PHQ-9. Scores are automatically populated and sent to our observation terms, which in GE is what flows to ECQM's clinical quality reporting, Hixney. So it's definitely not been a smooth process, but it's been performance improvement at its finest. So we started out in 2016 at a very low level, I think 5% perhaps. And we continuously are improving to the point where, you know, Ruth Ann's screen just showed us at 80% for Hixney. We've always been somewhere in the 80th percentile for the ACO as well. So I'm happy to answer any questions, but our workflow is very heavy on EHR customization, education for staff and nursing staff and providers. We also integrated a social worker into our practice so that anybody that scores positive on a PHQ-9, we have that integrated behavioral health resource that helps us with the documented care plans. But that's just like a broad overview. So I'm happy to dig in if people have questions.
Thanks, Amanda.
Amanda. And Amy McDonald, could you share? what your organization is up to.
Hello.
Hi, Amy.
Hi. We just wanted to share our process because we do our own coding. We're a pretty small practice. We're 15 people, 5 providers. And because we do our own coding and tracking, we noticed that it's harder to capture the negative and the positive CPT-2 code or the Medicare G code. So what we did, because I love MedEnt, by the way, we see that MedEnt has a beautiful feature of adding the CPT code selection prompt to a document. So once our clinical staff performs the PHQ-9 that MedEnt created, they will select the negative or the positive CPT-2 code or G code. And then that made it easier for us to run a report on the positives to make sure that we're following up and that the providers are doing their documentation in the follow-up. So it's just pretty simple for our process. But we noticed too that we were only doing depression screens for our preventative visits, and that wasn't enough. So we utilized the sidebar shortcut for DMHM so the clinical staff knows when that depression screening is due, and we've implemented that more recently to make sure it gets done at least one time during the calendar year. Because before our scores were low because we were only doing it during physicals and preventative visits. And that is our process.
So I had a quick question for either one of you. One of the things that we noticed when we're doing data abstraction from the offices, if people are utilizing the PHQ-2 and somebody has a diagnosis of depression, especially for depression remission, a PHQ-9 should be utilized. And many times when people are reevaluating, they are using a PHQ-2, which does not meet the measurement criteria when you're reevaluating for depression. So I guess, with that, have you run into any problems, in your office with utilizing the 2 instead of the 9?
Brenda, it's Amanda. So the modifications to our forms actually have it built into the coding that if there's diagnosis of depression, a PHQ-2 can't be used. It automatically flexes to the 9.
Thanks. And one of the things that I do like, and I know we're at the top of the hour, one of the things is, this working with your EMR vendor and utilizing and maximizing what you can do with your EMRs is really important because, not only in your workflow, but really cutting down on the time and effort, kind of like what Amy's doing on her end, being able to monitor, building that in so that it makes it easy for the providers and or staff who are working this. So I think, that's one of the key items I think we need to take away is working with the vendors. And certainly, Meta is very willing to work with any of you to help optimize, the opportunities that are available. So.
We are at the top of the hour. I don't know if anybody else has any additional questions. We can certainly stay for a few minutes and answer anyone's questions if they have the time. Otherwise, we will see you next month. If there are suggestions for topics that you would like to talk about, I'm going to encourage you yet again to send us forward those topics, or even, write it in the chat right now if you're thinking of something, and we'll put it on our list to look at as we prep for next month's meeting. We'll always continue to talk about some of the big ticket items, but certainly there's a lot going on in practices, and we'd be happy to have this time to be able to share initiatives with each other and see how we can work together. I thank you all. I thank our guests, Katie, and our colleagues from MedEnt as well. I will put in the contact information of the individuals so that if you do have questions, you can reach out to them. And again, on our last slide are some of those connecting points and information for resources that might be of help. Thank you all. Have a great day and a great month. And we'll see you next month.
Bye, everybody. Thank you.
Thank
Thank
you.
you.
Thank you.
Thank you.
Thank you. Have a good day.